Thank you all for sticking with us to the very end. I know it's been a long couple of days. And I know you're eating, and that's acceptable, and it's still going to be a little noisy in here, so don't feel bashful about continuing to eat. We're not going to have any pause that'll allow you to finish, so continue by all means. I'm excited to be able to moderate our local panel today, and one of our core principles in each of these symposia as we travel around the state is to make sure that we hear from local voices, that we highlight local successes, that we absorb and reflect on things that we've learned throughout the symposium in the context of what we could do better in the location where we are. And so again, I'm really excited to be able to introduce our four panelists today. We've got Maggie Luna, Executive Director of the Texas Harm Reduction Alliance.
Thank you.
We've got Mike Sasser, Community Paramedic and Captain of Austin-Travis County EMS. We've got Phil Owen, Chair of the Austin Area Opioid Work Group and Program Manager at Communities for Recovery. And we've got Dr. Desmar Walks, Medical Director of Austin Public Health. Now, I'm going to make my way over to the chair so that I'm a little less awkwardly separate, and I'm going to take on my role as moderator, and I'm going to start with 3 preset questions. So I promise there will be time for audience questions and input. But I want to start with some prompts that get us going and make sure that we understand what the services are that are provided by each of these critical organizations. So my first request of each panelist is to finish introducing yourself and then share what your agency is doing to address substance use challenges in Travis County. And I'd like to start with Dr. Walks and work over toward me.
Hi, Desmar. Glad to be here today. Really happy to be part of this community and APH, and working with many of you here in the room to address substance use disorder. I was talking with Mike, and we were just doing the high five thing because this is something that we've both been dealing with for years in practice. And I was telling him many years ago when I was working in a homeless shelter for women in DC, I was grappling with the problem of my patients who were heroin users who would inject as they were waiting for me, and we didn't have any of the services that we have now in our area to really give them some help. So Austin Public Health has been following the CDC guidance for addressing opioid use disorder and substance use disorder. We're using an evidence-based, multi-pronged approach in collaboration with many of our community partners here in the room, and we're working towards sustainability of that response that we're putting out there in our community, and braiding funds so that we can continue the work and get Narcan and all the things that we're trying to do to save lives. I'll pass it to Phil.
Hi, I'm Phil Owen, Program Manager over at Communities for Recovery. We offer a lot of services for people looking for recovery as they define it, and what that means is looking for people that are self-determined and self-defining their recovery, supporting their dignity of risk, whatever that may look like for them any given day. At Communities for Recovery, we are a brick and mortar on the Austin State Hospital campus, where we have computer labs and host many mutual aid groups and collaborative community partner groups around the county. The core of what we do is employ people with lived experience, recovery support peer specialists, which are, that lived experience is based on a history of substance use, recovery as they define it once again, But I would also like to qualify lived experience, that lived experience isn't just how I identify. I identify as a survivor of overdose. I identify as a father who lost his son to a fentanyl poisoning event. I identify as a person in recovery. So I'd just like to clarify that lived experience is that firsthand experience that impacts us so strongly that it becomes part of our identity. And so at Communities for Recovery, our focus is relationship services, relationship-focused services, where we are fostering and maintaining healthy relationships, working with our peers in ways that they define. They're in the driver's seat. We're there to learn from them, to explore, to understand them better, because we understand that those lived experiences are oftentimes intersecting with things as justice involvement, socioeconomic struggles, housing insecurities, and so forth. So we're out in the community and to create those relationships, become familiar faces, and to work with people on the goals that they see fit for themselves.
My name is Mike Sasser. I'm a captain with Austin Travis County EMS. I work in the Integrated Services Division. For those of you who aren't familiar with EMS, Mobile Integrated Health, and Integrated Services model, essentially we're the part of the 911 system that looks for the right resource to get to the right patient at the right time. Because we've learned that sending an ambulance to the emergency room is not a solution for every single problem. So we focus on trying to find the alternative solutions to that. And because of that, we have a big focus in both mental health and substance use. Our current deployment model when it comes to mental health is that we have 2, soon to be 3 full-time 24-hour mental health responders that respond to crisis calls and overdose calls and substance use related calls and all that kind of stuff. And then we also have 2, soon to be 3 full-time case managers on the substance use program who do daily visits and follow-ups and that sort of thing. The way the program itself looks is each day, every time there's a 911 call generated in Austin Travis County for some kind of overdose or opioid related issue or substance use related issue, that patient chart is then generated on a daily report at our C4 division, which is our communications folks. And so they review that chart and determine who out there might need some help. And then we send somebody out there to go have a conversation with that person. That conversation always starts with, "Are you okay?" Because we just looked at the paperwork from yesterday. It sounds like yesterday was a pretty bad day for you, so how can we help? Is kind of our base of where we start when we have this conversation with folks. And then that's a great opportunity to have a conversation about harm reduction. We talk about Narcan, we give out Narcan, we talk about starting small, going slow, we give out the information for the Never Use Alone site, we give out the Brave app, we do anything that we can to give to people resources so that they can stay healthy and stay alive and just be as safe as they possibly can. We're public safety, we're EMS, so I often refer to this as we're doing fire prevention for humans, is all it is. And then the other side of the program is the buprenorphine bridge program. And the idea behind the buprenorphine bridge program is if somebody is struggling and does need help and is ready to start trying to figure it out, we'll help them try and figure that out. We're gonna find you a clinic, we're gonna find you an inpatient program, whatever it is that you're looking for, kind of like Phil said, you know, like what does recovery look like for you and how can we facilitate you getting to that? And if that includes like starting you on medication, we'll go ahead and start you on buprenorphine ourselves. We'll dose you, induce you on the medications, and then we're gonna see you daily to provide daily dosing until the program, till you connect to another program. Our bridge program so far, we just passed our 500th case last week, and currently our success rate is about 93% of the people that we work with ultimately connect to another program.
Nice. Thank you all. So my name is Maggie Luna. I'm the executive director at TxSUS Harm Reduction Alliance. And we are the most comprehensive harm reduction site in Austin. We offer safe supplies, and we have a drop-in center over on 1803 East Cesar Chavez. And at that drop-in center, we have participants that show up every single day, and we have a shower, a hot meal, we connect them to resources, and then we also have an outreach team that goes out to different camps in different areas and helps connect people with safe use supplies. So it's really the most comprehensive harm reduction service that I can, and I'm really happy that TxSUS Harm Reduction Alliance hires nothing but people with lived experience. I lived 20 years in an opiate addiction, living on the streets, in and out of incarceration. And so being at the drop-in center every day is so fulfilling to me because I can connect with people on a level knowing exactly what they're feeling just by looking in their face because I've been there. And these people have a special place in my heart. And so I'm very proud of the work that's being done at Texas Harm Reduction Alliance. And so we provide peer support services on site. We also have reentry people who go into Del Valle and help connect services. And one of the things that we really want to focus on is the high overdose rate when people are getting out of jail. And so trying to connect with those people before they get out. And so that's of major importance for us right now. And actually everything, we connect with people that are going to connect with people that I'll never see. We're able to supply Narcan and safe supplies to people who are going to be up all night in these camps. They're going to be saving lives when none of us are around. And so that connection is so important for us to have secondary supply options. So, thank you.
All right, so y'all can see why we invited this particular group here to be able to speak to successes and challenges in our area. And so I'm going to move on to the second question, second prompt, and I'm just going to follow the same order for these next two, if that's all right with y'all. So Dr. Walks, what is the single greatest challenge related to substance use that you and APH anticipate encountering over the next 5 years?
Ensuring sustainability of the supply of naloxone and funding for all of the medication-assisted treatment programs, and also really working hard to legalize fentanyl and xylazine test strips.
What about you, Phil?
Sure. So challenges, I guess I would just like to say, one, I want to start by celebrating the progress that has been made with stigma within our group that we have here, right? That, stigma has not evaded the provider setting. It hasn't evaded the street setting. It hasn't evaded anywhere. But I think as providers of our various expertise that we have done a great move forward with reducing stigma a great deal. For the recovery community, this has been challenging. I think we're in a place now to where even just medication-assisted treatment is recognized as the evidence-based approach and welcomed into recovery. The idea that harm reduction itself, safe use, and for somebody to live another day is recovery, and that could look completely different for someone else, but I think inclusivity has been a challenge, but I would say moving forward, this message has to be broadcast to the community at large that we need to normalize those difficult conversations around drug use and understand those harm reduction principles, that drug use is going to go on. There's no foreseeable end to it, and we have to have those conversations with our friends, our allies, our families, our children, so on and so forth, and that's going to be the big challenge because there's a lot of misinformation and disconnection, which is a big problem there.
I think for me, the observation that I've noticed as a field paramedic and doing through the work over the last several years, it's the pollution of the drug supply. We have been following up on overdoses now for 6-7 years, I think is what it is. And we watched the fentanyl hit in Austin. Like, I remember having a conversation with a guy, asking him about his opioid use, and asking him, like, you use Narcan to resuscitate you, like, let's talk about your opioid use. And he looks at me and goes, dude, I thought I was doing cocaine. And I was like, oh crap, here it comes. And it's been like that. Now it's over the majority of what we see. Everything has fentanyl in it. If it's a pill or a powder, it's got fentanyl in it. And the only way that it's only gonna get worse. It's not gonna get better. It's not gonna go back to having true heroin or true opiates. We're gonna have this mix of opioids and all kinds of other stuff, and it's only gonna get worse as we go forward. And so we need to be better prepared, both as a system and as a community, to address this as it comes to us, because the overdose crisis isn't gonna get better, so we need to make sure that we're stronger when it gets worse. That would be great too.
So one of the biggest challenges that I see is with our state policies, with legalizing fentanyl strips, getting xylazine strips out, having testing for safe supply on the street, because that is where people are being affected. And so the people who are making these laws to criminalize harm reduction, to criminalize like the drug-induced homicide laws, that's not helping people get help. It's not helping people stay alive. And so these laws we need to be focusing on saving people and safe supply and safe consumption sites. I know this is Texas, but there's a safe consumption site for everybody who wants to go drink. You can go have a safe place to use alcohol. So if we're losing more people, we need safe consumption sites for those people too, you know? And so I know it's a radical idea, but it's definitely needed here in Texas.
And because the splintering and complexity of the drug supply came up, I do want to give a shout out to one of the posters that we've been displaying, the work by the Texas Drug User Health Alliance, and some evaluation by our own graduate student Claire Zagorski of their work, distributing pretty innovative testing kits for drugs that I think address our whack-a-mole approach to these individual drug testing strips, which still haven't been explicitly legalized, and the need to be broad in how we think ahead. The whole point of talking about the next 5 years is being prepared in advance, not passing legislation 5 years too late.
Right.
So thank you all for pointing out that aspect. The last thing that I'll ask before we transition to inviting in-person and online questions from the audience is, what is the single greatest strength that you've observed in our local response to substance use challenges that we can build on?
The strength that we have is that we have individuals committed to the cause that are working together to find solutions. So that is a position of strength that has propelled us in the last 3 years in a direction that I think we are going to win this fight. We are working together to put more naloxone out on the street. We're working to make sure that there's not a wait time to get in for treatment. And we're working together to move public perception on substance use disorder and making it something that's recognized as any other kind of medical condition rather than the fault of the person that has this condition. And that, I think, is going to go a long way to help us win this fight. And we're also working on increasing provider awareness of what the problem is and how there may be some contribution in the medical profession to people making this transition to having a condition that is lifelong. And we're developing a medical detailing program that is UT Pharmacy School is helping us with. So I think all of those things are going to help us strengthen our response and bring us to a place where we have people that have the help they need through these partnerships that we've forged.
Yeah, I'll build off that last point for sure. Is collaboration in our community is key. Travis County and Austin, just sheerly where we are at, we are very fortunate. That is a strength. We have great community partners. I think it's one of the superpowers that I see in our community, or the collaboration of community stakeholders and people that care. And then I would just say that employing people with lived experience, they're directly impacted, and including their voice at the table, wherever that table may be.
I think kind of the same thing. It has to do with, for me and for us as in EMS, it's the addiction medicine community here in town. When we first started this program, like I was just a paramedic who just showed up at Dr. Oshbach's clinic and said, "How do I work with you?" And she, just like everybody else in the addiction medicine community here in Austin, accepted us and welcomed us with open arms. We don't have to remind you how much crisis your patients are experiencing on a daily basis and how much they're going through. We just needed to remind you we're the ones that are there, and how do we get them back to you and get them the help that they actually need. And so that's, I think the collaboration and the way that everybody in this community who works in this profession has reached out to us and said, yes, we'll take them, we'll help you, we'll teach you, we'll come. Dr. Weems has come over and give lectures, Dr. Oshbach's come over and give lectures for us to train our paramedics to be better at what we're doing so that we can do more. And so I think the willingness and to fight and do whatever you can to help us help everybody has been huge for us.
Yeah, echo everything. Our relationship building that we've been doing on the streets with these people who are actually living this every single day. You know, we have a great team of people with lived experience who are going out and talking to the people that you will never see, will never see them. And so being able to connect those people to resources and secondary exchange, I think that's a strength, and we definitely need to build on that. And then we also have a great grassroots advocacy organizing team who is out there helping to, fight the stigma and push these laws. And it needs to be built upon. We need to continue to work together and value the impact of people who have lived experience. It's lived expertise. We spent 20 years getting our degrees, and so we might know what we're talking about.
All right, well, as our in-person audience, please feel free to move toward the two microphones in the room and line up there. And then our organizing committee chair, Dr. Lindsay, is going to help me with questions from HUVA. I'll just make one more comment that, I appreciate that most of you mentioned something about connected local organizations. And it was totally by happenstance that everyone I invited to be a part of the summit is a recipient of a new Austin Public Health contract from a SAMHSA grant. Hopefully it's okay for me to say that stuff, but if not, I did. I think we cover the gamut with those, from clinician education to field work and harm reduction and peer recovery services, that it does make it feel like it's taken some time, just as it has in every community in Texas, but we've at least started to build the partnerships that will hopefully help us moving forward. So with that, I'm going to first ask for an online question from Dr. Lindsay.
Okay, we have a couple questions coming in on HUVA around naloxone vending machines. I'll try to kind of sum these two up. What has been the public response to naloxone vending machines? How are they strategically placed? And then if any of you are aware of any kind of preliminary local outcomes.
I can say that from the 911 side, we get a lot of calls a lot of times, and we follow up with as many overdoses as we can and make contact and connection to as many people, and we see it on a regular basis, like especially in the one down by Sunrise that they set up down there. We see it all the time, that is getting used on a consistent basis, because that's a very, very rough area as far as like the opioid use and stuff like that. So we have a lot of overdoses over there, and I know that the downtown East Cesar Chavez location is also over by Cenote is really well used as well. So I can tell you from the 911 side, we definitely see it being used in the community, and they've definitely had an impact. What Emily has done with that has been incredible.
Now I'll move to our first in-person question, and not to suggest that you would do otherwise, but I'll remind everyone of our approach to the in-person questions. We'd welcome you to share your name, your affiliation, where you're from in Texas, if not local, and ask us a question for our brilliant panelists. Thank you so much.
Yeah. My name is JJ Ramirez. I'm an organizer at Vocal Texas, and I'm from here. My question is to you, Maggie, actually. What can people in this room and their friends and colleagues do to support people who are doing outreach work in the street in the direct face of state opposition?
Yeah, thank you. What people can do is make sure that people that are doing the actual work on the ground are getting funded, and the funding stream is sustainable, right? Because we have people who depend on our doors being open, and if we cannot sustain that for these people to have a safe space, yeah, we need funding. Make sure that it's sustainable.
I want to speak to that real quick, though, is that the conversation can't stop here. It's not just the people in the room. We need to take these messages home. We need to talk about them with our families. We need to talk about them with the schools. We need to talk about them with other parents. We need to talk about them with our kids, the other students. It can't just stay in the people that in the realm of the people that already know. You know, a lot of people don't even realize how directly they're impacted until there's a fatality or something significant that changes their life.
All right, let's go to our next in-person question.
Hi, yeah, Patrick Kennedy, Steve School of Social Work at UT Austin. Something that I've been thinking about today. That I think keeps coming up for me is how do we navigate people who follow a traditional model of recovery when they're thinking about abstinence only, and then introducing these new ideas of harm reduction into our recovery support services? How do we have conversations about that in the most productive way possible so that we're pushing toward change without asking for too much and then losing them? How do we balance those things?
I think the first part of that, first part of that is to have an understanding about the fact that that treatment can be successful, and that we are treating a person who's making a decision on when they want to be treated, and being able to support that just like we would any other treatment process that we engage in as healthcare providers. And then I know you.
I would just say, well, for one thing, abstinence is a form of harm reduction, you know, so we can share that lens. I've also had, you know, good feedback from reframing it for someone. If someone's smoking 2 packs of cigarettes a day and they decide they want to smoke 1 pack of cigarettes a day, could you support them in that? If somebody's shooting a gram of heroin a day and they want to shoot half a gram of heroin a day, would you support that? To me, there shouldn't be any significant difference there. The other thing too is to just, you know, we've got to meet people where they're at. The difference in somebody using every 15 minutes or every 15 years, it can look a little bit different, but it's not that different potentially with the contaminants that are in the supply right now. And honestly, why would we ever limit anybody into recovery? We're not an exclusive club. You know, we should have our doors wide open and welcome people wherever they're at with it. Because for some people, they're using drugs to cope with other areas of their life, and they're doing it successfully. You know, and that all use is not chaotic use. There are people that use drugs to stabilize their lives. And if we look at it more from a point of healing or to help stabilize suffering, that we might be able to view it in a lens that's easier to digest, you know. So just kind of reframing it for people that may have a hard time dealing with it.
I want to add to that too. I spent 20 years trying to work an complete abstinence program. And there was so much shame every time I relapsed that I did not want to go back. And so in order for me to, you know, reconcile this in my mind, I think about people that I see every day here in Austin who are freaking out because they don't have their Adderall prescriptions, you know? But that's okay because it's legal, right? And so when we're talking about abstinence and all I did was self-medicate for 20 years. And I honestly lost everything because of the way everybody else believed it was affecting me. But that's what it was. It wasn't, there are other people who are self-medicating every single day, and just because it's legal, just because they got it from a doctor, then it's okay. And so how can you preach abstinence at one point but say it's okay if you're freaking out because there's no Adderall being produced right now, you know, because a doctor gave it to you. And so we just have to definitely smash that stigma that, I mean, I self-medicate now by eating food, you know? And so there's always something that, I can't be abstinent of everything that's harming me. I vape now, that's harm reduction, you know? And so it's just, there's harm reduction in everything. Seatbelt's harm reduction, you know? So yeah, I just wanted to add that.
Yeah.
I'll add one more thing on our team. Our approach is always understand the science, understand the medicine, understand what's happening to you and why you need to take it. Like, we draw comparisons between opioid use disorder management and diabetes management because they're very similar when you line them up. Some people need massive amounts of methadone. Some people need massive amounts of insulin. Some people need Suboxone and naltrexone and that sort of thing, and methadone. And some people do glipizide and metformin and that sort of thing. Some people do beatings and therapy, and some people just go diet and exercise. It's about learning how to manage it and making sure that people understand it, especially people in the using community, because they're Googling the hell out of everything they can to figure out how it is, because their whole day is a matter of, like, it's just an ongoing quest to not feel miserable. And so explain to them why they feel miserable and what the medication is supposed to do and how you need to start to get control of it and management. And so that's why what we try and emphasize with our patients and the people that we're working with is understand what this medicine's for and what it's doing. It's not going to cure, it's not to solve any problem. It's just getting you off the roller coaster so you can start to figure it out, man. You know. So.
This isn't a problem that we're going to. No, hell yeah, Captain Sasser. No, this isn't a problem that we are going to just shame people out of or punish people out of. We're not going to punish our way out of the issue with substances. We need to accept people as humans. We need to have those human conversations and not a judgmental conversation. We need to support people's dignity, and that includes their dignity of taking risk, you know, whatever that risk might be.
All right, I think I see a familiar face in the crowd here with a question.
So my question, I guess, is more, you're commenting on something. One of the things that's interesting to me since moving to Texas is every community approaches problems differently. And I guess you guys have moved along, and Lucas, you mentioned it had taken a while to get there. If you knew then what you knew now, what are kind of the 3 or 4 things you'd say to a community that's just really starting? They're here, they're curious, they're ready to get started doing something. What are like the 3 lessons they need to know based on the benefit of your experiences over the past few years to jumpstart a new approach to substance use in another community in Texas from the Austin viewpoint?
I think the first thing that you need to do is educate your policymakers so that they understand why you need the funding, so that they can support that, because this takes money, it takes people, and we need to be able to compensate people for the work that they do, and we need the money also to buy medications and supplies and whatnot. So I think a real education of policymakers is needed. They need to understand why we need to legalize fentanyl test strips and xylazine test strips. And that's going to take real education and understanding about the comparison of this and diabetes. You know, there are 2 conditions that require medication. They require protocols that are set forth by peer counselors that have lived experience, and they need to start understanding that. They need to understand that we need safe places for this to happen.
I think also, you know, if I knew then what I do now, my son might be alive. I might have more living friends, more living recovery community, more living community, period. by being more inclusive and more welcoming, treating people like humans, having those human connections and conversations. I know that may sound pretty basic, but I think the solution is fairly basic when we open our minds to understanding that everybody's experience is different and they have overlapping struggles that are happening in their life, and to take the time to explore and to understand others better.
I think for me, I would look at it and say, I would tell myself it's not as hard as it looks, right? Like when you look back, when I look back at where we were, like, I don't get why it seems so hard to get to where we are now, because it feels pretty easy now. But the reality is, like, when I think about the very first overdose that we ever did a follow-up on, I read a report, I looked at it, said, this guy looks like he needs some help, I'm gonna go knock on his door, and I just knocked on his door, said, are you okay? And he said he wasn't, and we talked for 20 minutes, and then I made some phone calls. He said he wanted to get into treatment, to a medication program. I said, I don't know how to do that either. So I called Mark Kinsley, actually, and he connected me with a friend, and we connected him to somebody, and we got him into a program. And realistically, I spent 30 minutes worth of work. That didn't cost a lot of money. That was 30 minutes of my time just to make it. And the guy went back to school, he started doing all kinds of other stuff, he inspired his partner to get into help. Like, it wasn't that damn hard, and it didn't take that much money. I just had to figure out a way to get some Narcan and just go, hey, are you okay?
Yeah, I think that humanizing the population that we serve and realizing that they're not them, it's not us and them, you know, we are all one step away from being them. And so humanizing that and realizing that these are people, these are human beings, and if harm reduction was around whenever I was using, I wouldn't have been forced underground and using, you know, and contracting Hep C while I was in my addiction. And so being able to save so many people from that heartache is just, we have to make sure that those people are humans. We understand that it could be your mom, your dad, your brother, your sister, anybody. And yeah, and stop forcing these people underground. And so just being able to let people be people in public.
I'm going to pop over to the previously mentioned future Dr. Zagorski.
Hi, everyone. My friends and colleagues. My name is Claire Zagorski. I'm a PhD student with Dr. Hill at the University of Texas at Austin. I study translational science, and I've been a harm reductionist for about 11 years now, all here in Austin. Mark Kinsley was my first mentor. So I think we've almost skirted around my question. And, you know, we heard about overdose prevention sites this morning from Sam here. And I think I'm hearing more and more from people that they're coming around to the idea. It's starting to make sense to them. And in Austin, a huge thing for us is tourism. We're a booming city, we're a growth city, we're a party town, we're attracting money, we're attracting interest. And a huge thing that I hear from our community is I'm tired of seeing people using drugs. I'm tired of seeing people on the streets using drugs. So with that in mind, with the fact that we understand the evidence, we understand the compassion argument, we even understand the business and financial benefit to Austin, what are next steps for us? As our leaders, what are the next steps to getting on the road to getting an OPS in Austin? I feel like we're on board with it in our minds, and we're now at a logistical hurdle. So what are next steps gonna look like, and how can we work together to make this happen?
I think providing more supplies and making sure that we have more people on the streets providing clean, safe supplies and making that okay. You know, it's okay for people to send people to us, but they don't want to touch that, you know? And so being able to get a safe consumption site and get these people in somewhere safe where we can monitor and save their lives, you know, we have to make it non-taboo.
I think we're making progress, but we're not there yet. I think there's a groundswell in that direction. It's going to require policy changes, it's also going to require education of the public to understand that it's not just them, it can happen to you too. And an understanding that just like you might know how to do the Heimlich or CPR, you need to know how to use naloxone. And that's the groundswell that we've got going. And I think as we continue with that push to have people understand what it is that's going on, that we will influence policy and hopefully change it.
Is there any way the people in this room can help you, Dr. Walks, and other people in policy positions? Because I feel like, if Austin gets one, it'll be a cascade for the rest of the state. It's not even just us. If we happen to be able to break through that wall, all the better. But, what can all of us do? Just keep talking and keep pressuring until we kind of get a public consensus?
Yeah, that and educating and passing the word and disseminating the information, because we are all in this room great advocates for the cause, but we need to pass that on. We need to get out the vote, so to speak.
And we need to bring people like Sam to help show us the way, Bring in people who are already helping people, saving lives, and learn from them. So, thank you, Sam.
Thanks, y'all.
I think we've got a
Ready
Hoover
for
question.
Another question on Hoover?
Right.
This is maybe a little bit of a follow-up to that. So for nonprofits or other organizations who can't lobby, how specifically can they advocate for policy reforms while still adhering to no lobbying rules? Specifics.
Could you repeat the first part of the question? I think it might have been reverberated.
For nonprofits or other organizations who cannot lobby, there it went, sorry. How can their staff or teams advocate for policy reforms?
I think as a 501c3, you do have a certain amount of leeway there. And I was in policy before I came to THRA, and one of our main objectives is training people in the community to go lobby for themselves. So teaching people that they have a voice and showing them the way of getting to, call your representative. You can do something from where you are, whatever it is. And I don't have to influence what you're saying, but I can tell you how to get there. So that's one way to do it.
I know I don't know much about lobbying, but I know a lot about making a lot of noise until they let you do what you want to do. So I can tell you that let's make a lot of noise, and then they'll have to listen.
I think also, we've got to, it's about that voice. It's about how loud that voice is, how articulate that voice is, and that the message is consistent. We're not going to punish our way out of this, but we might vote our way out of this. We can all show up and do our part with that. I think, when we consider, one example is that our children have much more information about how to acquire a dangerous substance than they know how to help someone that's struggling with a dangerous substance. Mm-hmm. And we need to flip that paradigm because, it's cliche, but it all starts with our youth.
I'll just pop in and say that as a faculty at a public university, certainly walking that line and finding a way to influence policy while adhering to appropriate rules and boundaries is a challenge. And I think that what I try to do in our educational efforts and even in testimony, and what I think many in this room try to do, what we want to do with this event is to provide breaking evidence-based information and guidance, and to bring people in who add personal stories and anecdote to that in a powerful way. Again, calling back to Sam and everything that he was able to do in this room to, as Van mentioned in his own statement, to change hearts and minds even of people who already had heard a lot of the arguments, but had never felt it put together in that exact way. looking at the folks on the stage here and thinking about the other connections we have in the community, hopefully there's enough people wearing the right type of outfit or uniform to influence everyone who needs to be influenced to have their mind changed and do what's right. I'm going to bounce it back to Phil again, only because Phil has shown a lot of humility. Phil should be the one moderating the local panel. I mean, what Phil did with the Austin area opioid work group, I think has had a tremendous impact on just awareness of who's doing work and wants to do work, and maybe even to some extent exposing people who want to be seen as doing work but don't really do work. So Phil, in that work, the work group, is there anything that's really stood out to you in terms of what a community that wants to put that sort of thing together, or a lesson that you've learned from it for our own community that maybe any of this has stoked and we haven't asked quite the right question?
I just want to say that, you know, the group itself is the one that carries all the value, because it's the partnerships and collaboration and people that have a passion for talking about 6 years ago when we first got together, was talking about where the opioid issues were and how people were connected to them, to learn from each other, how their organizations function, the gaps they see in services, and to get together and collaborate. And at that time, we broke into work groups and started to talk about life domains and quality of life markers that where some of these gaps were. And I can say too that some of those initial things from that very first meeting we had, I know for Communities for Recovery has turned into 5 of the programs that I manage, you know, over the course of that 6 years. So when we collaborate and when we show up in numbers and when we know what each other's lane is and we come together, that there's a lot of strength in that. And you know, it's something I think that if we can replicate that and build upon that, once again, going back to those strengths, you know, just really looking at that, it's like sometimes we have to show up on our own dime to make a difference. And it doesn't always happen within my workday, you know, and a lot of that passion comes from having been a father that had loss, you know, so you just have to find where your commitment is and show up for it. And it's not just showing up to listen, it's showing up to get involved and engaging the community.
Question over here.
Hi, yes. My name is Yima. I'm a first-year med student, also peer support recovery specialist. I have a bit of a controversial question. I ask it not because I agree with the premise, but I think it's important for us to talk about. There's been a lot of talk about things like harm reduction, destigmatizing drug use, which I totally agree with. And what would you all say to the many people who consider themselves to be in recovery, which to them means complete abstinence, and are thankful for the fact that there is a system in place that is really rigid, that doesn't allow drug use, that their treatment center would have kicked them out if they used, and because of that, they were able to completely abstain from all drugs? And how do you communicate your message to people like that?
There's room for everybody, right? Some things work for others. Not everything works for everybody. You know, one thing I've learned, that people have recovered in unimaginable ways when I started this work, and I've learned so much that I can't predict what someone's success might look like. I just know that success has happened when you empower people to be in control of their own choices. And that success doesn't have to look like my recovery. It doesn't have to look like abstinence. It doesn't have to look like following a treatment plan that a medical provider gives me. Sometimes that looks like, you know, I have to own who I am and my choices and be in the driver's seat, you know, and I want to empower others with that. It can be difficult. Oftentimes the most resistance we have is from our own community. And when I say our own community, especially our recovery community, because we use maybe terms that are different, or we have these old school, or we have things that have worked for people historically, but we have to look at the doors that have been closed to others. I can't tell you how many people that when the doors are wide open, they find recovery in some form or fashion. Life gets better for them. It may not get better by the way someone else sees it or by their measure, but it gets better by that person's measure. And to me, that's what really matters, because when you start to get that ball rolling, it creates motivation, And it's that self-empowerment piece, to where hopefully, and for some people, that's just living another day. I wish my son had another day. Maybe his choices might have been different that next day. So what was my loss was also a great opportunity for me to understand what recovery could be, and that it's not always abstinence. As a matter of fact, especially in this landscape, someone that's been abstinent for a long time that use a highly potent drug that has fentanyl in it or something is more likely to overdose or have a fatal event. So yeah, I think we have to really understand that, and also look at, the fact of the matter is most people in the world recover naturally, not from treatment or 12-step or anything else. They recover naturally without any assistance. So, the power of one person's choice is huge, is actually the dominant recovery. So once we start to look at true evidence and the reality of recovery, we realize that we're all just fractions of what works for people. And there are pathways to recovery I haven't even experienced yet that I'm sure is working for someone. And I think we just have to open our minds to it and understand that though I may cling real tightly to what worked for me, it doesn't mean that's going to work for the next person.
I also want to add that, I was constantly going into a 12-step program who every time I relapsed, I knew I could not walk back in and face those people. And so although it does work for some people, that rigid, program does work for some people. My dad has 29 years in sobriety, and he goes to a meeting every single day. And it works for him. But I also know that we lost a lot of people that it didn't work for. And so, having people who need that is great. But just like we don't want to be judging them, they shouldn't be judging someone who's not there yet or may never get there. So just respecting the fact that, yes, we all have our own path, whatever it may be, and we just want you to come back, no matter what.
Your question makes me think, too, as somebody who attends, speaks at, and facilitates these types of events, of the risk of tokenizing a single person in recovery and the way that that has led to a lot of bad policy decisions. Picking one person who meets our definition, who's part of this kind of survivorship bias issue where we only listen to and value the voices of people who made it by that rigid definition. And so we just want to thank again everybody who's been a part of this event, who has lived or living experience with drug use, who's hopefully helped us to demonstrate that they're not a monolith, that there are different views and different experiences within that group that all deserve to be recognized, and having one person with lived experience give a talk at the beginning of your meeting is not really given a great spectrum of insight. Got another question over here.
Hi, I'm Josh from the UT School of Social Work, and I live in Austin. One group I haven't heard talked about the past couple of days is people who sell drugs, and I can imagine there are a lot of reasons for that, but I'm curious if there's anything that you all know or think we should understand, or even if there are any interventions with that population.
So once again, I'll go back to my experience as a former user and a father that lost his son to a fentanyl overdose event or poisoning event. Is I'm very transparent about I have conflicting opinions about people selling drugs, because as a father, his mother really wanted to go after everybody involved, and I understand that as a former user. I also understand the needs that I had when I was struggling to just keep up with my day-to-day grind. And the reality of it is I wasn't profiting from selling drugs. There was never any intent to hurt anyone. Most of the time it was to just supplement my own use. So we have to look at, the inequities that are in place, that not everybody, sometimes that access to that kind of money is access to money that somebody else would not be able to make anywhere else. So there's a lot of things in place. I would say that just honestly, I have different views of it from both of those pieces of my experience, and I'm okay with that. Sometimes it allows me to give confusing answers like this, but it also allows me to ponder the reality of it's a very complex issue. When I think of violent situations, or we talk about intention. What is the intention of somebody? Is the intent to truly harm someone? And then I'll go back to, these are situations we are not going to punish ourselves out of. We've been trying to punish our way out of this forever, and it's not working. So we have to look at what else could work, and we have to understand people and the ways in which that they may not have privilege that other people have, and that affects their actions. And I think we have to look at it from a realistic perspective like that in order to better understand the solution.
Another question for y'all has popped into my mind. So, there was a naloxone listening session yesterday. While a lot of effort has been poured into increasing access to naloxone for overdose reversal, we know that we don't have enough in our community or in any state. It's not a Texas problem, it's a national problem. We really don't have enough to achieve quote unquote saturation. And so in that resource-limited environment, we've had discussions at this event about youth and adolescents, about pregnant and postpartum populations, about people who use drugs, people who use opioids, people who primarily use other drugs but might be exposed to potent synthetic opioids. Maybe one of the more difficult questions here, how would you, or how does your organization prioritize access to naloxone that you have to distribute when you have a limited availability of resources? How do we look at a community like Hays County, where I've been at, and we've had some adolescent or even younger kids experience fatal and non-fatal overdoses, and decide how to allocate resources? Is that something any of your organizations have faced or thought through at all?
And prioritizing getting it into the hands of people who are using and their families, and in public spaces and places where people gather, and trying to make sure that we have adequate supplies at our large events so that people in those events, if they encounter somebody who's overdosed, will have access. So that's what we're doing. We're also getting it into the hands of people like Texas Harm Reduction, because they can get it where it needs to be.
Yes, I was going to say that everybody who comes to us gets what they need, and they'll ask us, what they need, and educating those people like, hey, look, just if you see this while you're out there, this is how you use this. And we hear all of these stories of people who are being saved when nobody else is around. And so I think just making sure that population is getting everything that they need.
I think it's a fire extinguisher scenario too, Anybody that comes to Communities for Recovery and asks for Narcan is probably somebody that needs it. They're either consider themselves a potential bystander, or they're somebody that uses it. And I think we also need to understand not everybody that uses drugs discloses that they use drugs. So if somebody's asking for it, I don't want to challenge that. I think, going back to the fire extinguisher analogy is that, yeah, the supply does bottleneck here and there, but we need to normalize stocking Narcan. We need to normalize the idea that it's a fire extinguisher, and just because you give someone a fire extinguisher doesn't mean they're going to light their house on fire. And just because you give somebody Narcan doesn't mean that they're going to use dangerously. And also that when we stock Narcan, and I think with regards to the supply of it now, there's this understanding of, well, now that people can get it at Walgreens, and this has solved the problem. And well, the reality is that not most people that are directly impacted can't afford the $45 to $100 that it costs at the store. They may not be welcome in the store. They may not be able to go into the store, may not be willing to purchase it from people. People may not want to use their insurance card. A lot of issues with access or this misinterpretation that now the problem is solved because it can be sold over the counter. So there's also people that are using Narcan, saving a life, but the Narcan's not being replaced because we've solved the problem, and that's not true. The fire extinguishers have to get put back on the wall so they can be used for the next fire, should a fire happen.
As an organization, when we first got Narcan, we didn't have like grant funding or any special directive to go do this, so we didn't have access to a lot of it. So we got it through our community partners and the relationships that we built through Blue Bonnet, through Texas Harm Reduction, to UT Health San Antonio, and so many other places that we were doing it. And we did start to get to a place not too long ago where things got tight and the supply got tight, and so we had to like split the boxes and put them in 2 different bags to kind of stretch it out a little bit more. What we're doing now is we're partnering up with APH, and we're doing a lot more work with them. Now we're able to give a lot more Narcan, and we have access to it, and we're putting it out in as many places as we possibly can. And so we're increasing and bolstering that through our partnerships and relationships.
Did you want to speak to rescue breathing? Because I think that's a big point that gets overlooked a lot. If somebody doesn't have Narcan.
Yeah, that's one of the things that we're putting together some public Narcan education training that we're going to be rolling out with APH. And one of the issues that came up when we were talking about Narcan training was rescue breathing. And there were some people that didn't like the idea of rescue breathing, and they were like, "Why did you include that?" And I said, "Because I'm a paramedic. That's how my brain works." And so it's extremely important to just maintain some kind of level of oxygenation for a little while if you don't have Narcan. So we're going to start putting face shields in all of our kits as well to kind of make sure that people have access to that sort of thing as well, and kind of emphasize teaching people how to do rescue breathing as well. Because whereas people have objection to it because of their own personal reservations about putting their mouth on somebody, that's understandable. I can respect that. You don't want to put your mouth on a stranger, but at the same time, like if you have a barrier device, there's nothing that's going to harm from it, and you can save someone's life if you don't have the Narcan. So let's be open to it.
I think we've got another audience question over here. My apologies if I made you wait a long time. I think my view over there is a bit obstructed. I'll try to do better for that side of the room.
Not a problem. My name is Jim Patterson. I work as a senior counselor at Olive Branch Recovery. Also have a little company, Allied Substance Abuse Associates, out of Montgomery County. You know, I live in the Conroe area, and I've had the pleasure of being on the Addiction Studies Board for Behavioral Health Suicide Prevention that meets in the Tri-County area, and it's through Judge Wayne Mack. And you know, Travis County has come so far in getting, you know, to be able to see this panel up here and what you've done, what you put together, and how much effort you represent that's been going on. We've had a lot of effort too, and we have some really key players. One of them, for example, is Dr. Kristen Clancy. She's a doctor in pharmacology. She's helped set up the distributions point for Narcan, you know, the distribution machines. And there's a lot of new thinking that requires us to end the siege mentality that we've had for a long time. We have to abandon that and embrace the solutions that's proven to work. You know, there's a Malcolm Gladwell wrote a book called The Tipping Point. And I feel like Montgomery County is just at the tipping point to really getting involved and to really getting the traction that you all are showing now. And I'd like to know, if we got a board together, could we recreate this board here and as a consultation? Because we have to have, we need a lot more people on board for us to cross over to the other side. And most of them are judges. They need to hear from folks like you. And I just wanted to affirm you for your efforts and affirm everybody here for being part of the solution. Thank you.
I spent a lot of time in Montgomery County jails, and my daughter actually lives in Montgomery County. And so I make sure that she always has Narcan and she knows how to use it. She goes to a very upscale school on the lake, and it's just, you don't talk about overdose, but her friends are buying drugs on the internet, and they're probably more likely to overdose than somebody who just, anyway. So Montgomery County, it needs to be infiltrated from the inside out, because those people who are in power are the ones who are so, well, you shouldn't be using, this is the, but their kids are the ones providing. So, yeah, we just need to be in there.
Right.
I'll just say I know that our symposium team would be excited to talk to you about any opportunities to bring or support education and coalition building that way. I think that's why Dr. Potter's made her way over to you. And that Phil, again, not singing his own praises, but knows a lot about what it takes to get the right people in rooms together. So I'll volunteer that you should contact him.
There you go. That's how I got started.
Who was at the mic next? I'll let you guys
Mr.
self-police.
Mendoza was first.
Okay, thank you so much.
Well, thank you. Yes, Eddie Mendoza. I work with the Texas Department of Criminal Justice. And really, I just want to make some comments. First of all, thank you, panel, for your experience, your challenges that you provide, or that you give us, and how to deal with this crisis that we're dealing with. What I want to just make a few comments is this. A question was asked about what do we do with the drug dealers? And, is there some kind of service that how can we intervene? One of the things that I've been doing is that, well, first of all, let me just say this, that my father was a healer, and so he would heal with his hands. And I remember as a kid asking him one time, why are you this person came in with an injured wrist, and my father was kind of massaging the shoulder, and then he went down to the wrist. And then I said, why did you start over here in the shoulder? He said, because you got to find the root to the problem, which caused that injury. And so really, you got to start where it begins. And so I share that because what I've been doing for the last 10, 15 years is going to Mexico and working directly with prisons, substance abuse treatment centers, and the community. And one of the things that I kind of like my father said, you got to go to the root. We definitely have a crisis here. There's no doubt about that. And it's not going away, as you said. So my thing was to go down there and begin to work with them. And going into the prisons, this is the most violent prisons that you can think of, that can't even be compared to what we have here. These are substance abuse treatment programs that if you were to go there, and for those that license substance abuse treatment programs, you will be going like, what is going on here? How can you provide treatment in these settings? But they have what they have, and so we deal with them. And so my thing was to go there and educate them, work with them, train them on how to better work with their clients and their inmates and in the community. Going into the most violent states that, for example, we hear on the news or the safety, don't go to those states because of the violence. Well, you will see me on those states going into those communities to work directly with the communities to help them not get into this violent crimes that they're there. For example, the cartels, where they will recruit kids to go and work for them so they can mix those drugs. It was mentioned, for example, that, the person that said, hey, I thought I was just using heroin. No, you were using something that had more than that in that mix. And so dealing with those kids, for example, or those cartels that mix those drugs, we're not getting what people think they're getting. And so my thing was, how can I help those communities, those kids, for example, not get involved with those kind of activities. And so it's kind of like my dad said, you know, you go to the root, you work with them. My question is, and it really is for all, is I do this on my own. This is not something I get funded for. Is how do we, how can I get some help in doing some of that? Because last year, for example, I raised some money on my own to just go and work with a school that there's so much violence, drugs, kids going into the cartels, and raise enough money to work with that school on several activities that I did with them. So my question is, how do we, you know, how can I get some kind of that help? That's it.
No, appreciate you being here, and hopefully there's some networking opportunity there. I wonder, I don't know, most of us being more focused on Austin area services, whether, is there any sort of networking through TxSUS Harm Reduction Alliance to try to support grassroots folks in other places, and anything that's going on in that regard?
Yeah, we have our capacity building manager working on connecting people all across the state. And so in that, the call that we have once a month, we talk about what's going on all across the state and how we can connect with each other, how we can help each other get resources into our communities. And I mean, it would be amazing if we could all network and organize together to bring all of these resources into the smaller communities that don't get access. And so, yeah.
Lucas, just on that front, sir, I can connect you with someone from El Paso that we work with who does work across the border in Mexico, if that's what you were looking for.
You know, I just came from El Paso.
Okay. Yeah. So she actually works in Mexico, so if that's of interest to you, see me after this and I can connect you with her. Thank you.
Adrian was waving me for a hoova, but I'm going to go to Dr. King because I struggled to remember his last name earlier and called him Van, so I'm just going to let him ask a question now.
Yeah, I go by other things as well. I've had a little time today to reflect on my sort of change in appreciation for this. And the thing that flipped for me, I think, is really the caring for people. And I think that some of our labels that we're using really are so loaded that they get, you know, they interfere with that conversation. So for at least for me today, I think that the thing that's most powerful about this is, you know, caring for people, you know, loving them as we had heard, helping to sort of remoralize them so that they can, you know, live a more fulfilling life. And so I was just wondering, anybody have any thoughts about how to perhaps try to change this conversation so there is, I mean, I understand that it's important at times to, you know, be loud and to, you know, be heard, but I also wonder if there's some way to try to, you know, change the conversation a little bit to really put it where the focus is, which is, you know, improving lives and really caring for your other community members. So,
I think sometimes it's, you know, having those loud voices, but also providing that space. You know, sometimes it's called safe space. I tend to like the term brave space, where things are said, to sometimes just sit there and allow the space for somebody to be able to say something, to better understand them in ways that you may not, or they may not be able to say to anybody else. So to allow that space, yeah, it's great for our voices to be loud, but to also, we need to listen and allow other people's voices to be loud.
It's also important that we teach our kids that people who use drugs are not bad. We see all the time people saying, ooh, don't go near him, don't do that. That's terrifying, I'm scared of them. People are carrying guns. I used to walk through 4th Ward with no shoes. I never needed a gun. So it's just how we're teaching our children, who will be our future, how to view people who use drugs. And they're all humans and we all need love.
I think for us, like what we train our people is we start with we're no judgment, no anything else. We just want to see, like, are you okay? What can we do to support you? And just meet them where they're at and treat them as a human being is sadly is a huge start for medicine, to finally start treating people like a it's a novel concept. Let's start treating the humans like humans. But yeah, I think for us, that's our approach is making sure that we're coming from a patient-centered approach first and meeting people where they're at and trying to help them in the way that best way we can.
I'm hoping that as we start this medical detailing program across the county, that we'll meet providers where they are, not just the providers, but their staff, and stop that stigma of, oh my gosh, this person's coming in for their narcotic prescription. Oh my, that pushback that comes with all the, attendant worry about what am I going to do with them? They're going to be this, that, or the other. All those preconceived notions, and that we'll be able to give providers and their staff a way to approach patients in a more culturally humble way, so that they can guide people through the process, link them to treatment if that's what they want, link them to harm reduction, peer support, and remember that they need naloxone just in case. We're hopeful that that's what's going to happen.
To choreograph as we approach the end of the panel, we're going to take another HUVA question, another in-person question, and that'll be all. I'll close with a final little prompt for the speakers, but just so there isn't unnecessary standing.
Time-wise, we can always take these online as well. Take our last in-person.
Hi, I'm Cheryl Friedman. I'm an RSPS and an MHPS at Communities for Recovery. So I was talking to somebody that created an RCO in California, and she told me that in California they were shutting down a prison because they figured out it just didn't work. So I was just wondering what you guys would do with this opportunity here in Texas, if that happened.
To shut down a prison?
Yes.
Abolition, yes. Stop criminalizing people who use drugs. Stop filling our jails with people who have drug problems, Stop criminalizing Black and brown communities,
Keep kids in school.
Yeah.
Let's use that building to make a resource center too while we're at it, right? Big building, good real estate.
I would invite everybody in this symposium to come to the table.
Yeah.
To talk.
TDCJ has shut down a couple of units, but they're being repurposed into immigration facilities, but that's a whole different policy.
Well, on a more positive note, I'll say if you were in the workshop earlier with Brad Ray and Brandon Del Pozo, you heard that of the, I believe, 19 locations in New York City that had SSPs and the 2 that turned into overdose prevention centers, there was something along the lines of a 80+% decrease in arrests for simple drug possession in those areas, and that could lead to maybe the less need for some of that space if we changed our approach. So with all these things in mind that we've heard from the audience, I want to throw it back for one last comment from each of our panelists, and you can feel free to get creative and tangential, because what I want is the thing that you're thinking that you haven't been able to say. But I'm going to give this as a guidepost that I think a lot of people who've stuck here till the very end are activated members, and they want to know what they can do to improve services for people who use drugs, for people with substance use disorders in our community, both or either. What would you recommend to them as paths forward from your perspective?
I want us to get everybody to understand that this is a medical diagnosis that requires the same sort of care and compassion that we approach, hopefully, every other diagnosis, and that people that are living with this need our help, and they need different varying levels of that depending on what their risk tolerance is. You said it better than I, but that's what I want us to get to, because I think if we can change that perception in the public eye, then we can get this groundswell of help that we've started over the hump and get the things that we need in place for people.
I think so. For recovery-oriented systems of care, if you have one in your area, take a seat at the table, invite people to have a seat at the table, invite the communities that haven't been offered a seat at the table. You know, if you don't have a ROSC in your community, a recovery-oriented system of care, or an opioid work group, or wherever your passion lies, start one, invite people so that these collaborative groups can share their experience, share the gaps in services, you know, or where the existing services are, so that people can get connected from all the communities in your area. And yeah, take that seat at the table and invite others to it. And you have to be part of the movement. It doesn't move without your participation.
I think for us, EMS and public safety is uniquely situated to really have an impactful presence in substance use. I often say that I think everybody would agree that there's two sides to substance use. There's using and there's recovery. On using, we give you harm reduction. We do whatever we have to do to help keep you alive, to stay safe. And recovery looks different for everybody. It's inpatient, it's outpatient, it's medications, it's abstinence, it's meetings, it's whatever. But in between those two spaces, there lies some kind of crisis and type emergency situation that usually happens. And more often than not, involves people in uniforms with radios. A lot of times it's guns and handcuffs. More often than not, it's Band-Aids and scissors. And so we have a unique opportunity to help people navigate that scary piece in between the two of it, and let us help you get over to the other side of it. And I think EMS around the country is uniquely situated to be impactful in this space. And we spend a lot of time lately talking to EMS systems from all over the country, and they're asking us, how do we do buprenorphine? How do we do some of the stuff that you guys are doing? And we're trying to get them involved as much as we can. So if you're not from our community, maybe in your local community, look into the EMS systems and the 911 systems and find out about their mobile integrated health programs, and find out if there's a space where you can work with them to provide resources to people who actually need it when they need it.
And I would say bring more people who use drugs to places like this, so we can find out from the people who are actually living in this field, you know, let them have conversations at these conferences, and value people with experience, and let them help us. Like, I don't know a lot of things, you know, and so I would rather go to somebody who is actively living a life that would like to continue living. And so just making sure that we bring those conversations in, and we are normalizing all forms of recovery, no matter where we are, you know, and it's this or that, you know. Just continue to bring people to the table and value experience.
And with that, please join me in thanking our closing panel.